My name is Devontae Springer. I'll be helping moderate this. We have Christian Skillman, Camden Webb. They will be talking to us today about school-based mobile crisis as an equitable and trauma-focused approach to supporting students during mental health crisis.
Good afternoon, everyone. My name is Christian Skillman. I'm one of the clinical service supervisors with Solano County Office of Education, our clinical program, and I directly oversee school-based mobile crisis, and I'll turn it over to my director.
Thank you, Christian. My name is Camden Webb, Clinical Services Director with Solano County Office of Education. I'm excited to present to you today on the program that we have developed really successfully over the past couple years. So the learning objectives today, we're going to kind of set down the foundational why, which may be a review of what you already well know, given the current climate of mental health and our young people. But for those who aren't as grounded, we wanted to speak to that. Then we're going to talk about the launch. So if you do decide to go in this direction, what are some initial components that you're going to want to consider and put in place to start the launch of this program? And then Christian's also going to walk us through the daily operations. So what does it look like to run a school-based mobile crisis team on the day-to-day? So setting the foundation. So suicide being the second leading cause of death among people ages 10 to 24, and recognizing that the rate of suicide has increased nearly 60% since 2007. In 2019, we saw just astronomical rises, particularly with our adolescent female youth in suicide attempts. And the data that's coming out since the pandemic just only shows that the problem is one, grown, but I think also given young people permission to come forward more with the feelings that they're having. So we realize the problem is vast, but we also realize that there's a call for help. And so we can step in to support these young people and turn this number around. In 2020, murders by juveniles acting alone increased 30%, and murders involving multiple juvenile offenders increased 65%. So recognizing that we're not just looking at suicidality, but homicidality is becoming an increasing concern. We all see the frequent school shootings and community shootings. And so as part of our mobile crisis, this is absolutely a trend that we are sharply looking at and seeking to also turn the numbers around by responding to these young people and getting in front of an event like this. So the projected outcomes that we laid out when we recognized that we needed a school-based mobile crisis within our community. And I will say that we, in Solano County, we have a community-based mobile crisis that also responds, and then a school-based that is solely focused on the schools. So it's rare that our community-based mobile crisis responds to the school sites. And that was very intentional. Being a county office of ed, we have strong partnerships with our district. There's an automatic trust that happens in schools, which tend to be very insular, and even more so as a safety precaution these days. So we wanted to have a school-based mobile crisis with partners that the schools were familiar with and would be comfortable having come in and onto their turf, as to say, during times of crisis. So with that, as we built the school-based mobile crisis, we knew that we wanted to have a trauma-informed and culturally relevant crisis services, which really ties into number two, that we wanted to move away from having law enforcement. So typically what would happen is the young person would be identified as being suicidal or homicidal, and then an SRO or law enforcement was called in to the situation. And we recognize, particularly in some of our communities, that only heightens the crisis, can even create trauma responses. And law enforcement was pretty honest in saying this isn't even our wheelhouse. We don't receive particular training in this. So sometimes, not even making the correct call because they simply didn't know how to do the proper assessment. We wanted to be able to decrease the amount of time by school administrators and counselors addressing crises, recognizing that when you have a suicidal student, to do a proper assessment, safety plan, talking to the parents, talking to the teachers, if it's homicidality, calling in law enforcement, that can peel off a school administrator or counselor, anywhere between 2 to 4+ hours. And this is happening frequently at some school sites nearly every day that they're having to address these. So we wanted to be able to give them back the time to hold a regular counseling caseload, to be able to handle what they needed to at the school. And we would come in and pick up that time. We were definitely hearing stories of young people sitting in emergency rooms, and this is, in the heart of the pandemic, sitting in ERs with very sick people in hallways, waiting up to 4 or 5 days to receive that crisis assessment to determine whether they needed to be held longer or not. So we wanted to decrease the reliance on ERs and crisis stabilization units. We wanted to successfully stabilize youth in the community without even having to go to a CSU or ER. So our goal was 80%. Can we go in and stabilize young people by developing a safety plan, talking with the parents, linking them to services same day to get crisis appointments, so then they're not having to have the experience of being on a 5150, being transported, sitting in an emergency room or a CSU, which in our county is a majority of adults who are in their own crises. So minimizing that trauma. Certainly reintegrating them into school in an informed, supportive way, so they're not coming back into school and being given, here's the stack of assignments that you missed while you were gone, but really working with the school to talk about how do we have a supportive environment, what can we peel off so that they don't have the stress of schoolwork when they're just trying to reacclimate to their peers and teachers in the school environment, and then ultimately to save lives. And so you're going to hear Christians say it over and over again. The key piece is relationship as the foundation. So all of these entities that you see around, if we didn't already have the relationship, we quickly had to build it so that the trust was there. So we had sometimes we need to call back like that, having that relationship. We were on speed dial with all of these organizations. So starting at the top, of course, school districts needing to have the buy-in from them. There was some school districts who were like, yes, thank you, we need this right away. Others, it wasn't their process. It wasn't what they were accustomed to. We really had to say, trust us, let us try this out. I will say that our most resistant district at the end of our first school year came and said, we were wrong. Like, we can't imagine. And they actually are our highest utilizer to this day. So building that partnership. County Behavioral Health has been key. They're actually our primary funder of this program through some state money that routes through them. When we realized we quickly needed to get more staff, they were there to advocate on our behalf. Law enforcement, especially with the homicidality cases, we're needing to outreach, collaborate. So knowing all of the law enforcement entities in each of the districts within we work. Fire department wasn't on our radar, but we did realize that one of our smaller rural counties, anytime law enforcement responds, fire department co-responds. So when we started going out frequently to these school sites, the fire department was like, okay, this is a waste of our resources. Why are we being dispatched each of these times? And so systemically, we had to figure out a different way where they wouldn't get that contact. Ambulance company, we contract, well, County Behavioral Health contracts with an ambulance company to actually pay for the transports so that financial burden is not on any of the families. Dispatch centers, that was important more so in the beginning, where schools were trying to figure out, sometimes they would call 911 because that's what they were accustomed to, and working with our dispatch centers to let the schools know you don't have to go through 911 anymore. You can now route directly back to the mobile crisis hotline. Our community-based organizations, so knowing who provides early psychosis, who has full service partnerships. It's just been really important for us to understand what are the resources within our community so that we can appropriately link families. And then lastly, medical insurance companies. So we do provide case management to all of the young people that we see. And yet we know we can't just tell a parent, oh, call Kaiser and request an appointment. We had to learn what are the ins and outs of TRICARE, Kaiser, Anthem, Medi-Cal partnership, so that we could guide parents on what are the buzzwords you need to say, when does it make more sense for us to get a release and we call on your behalf, so they could successfully navigate those conversations.
So now we're going to transition into talking about the program launch. We knew going forward that we would need administrative support. Our secretary, who has truly evolved into being the backbone of everything we do. We knew we needed a clinical supervisor. We knew we needed responders. We were contracted to support 45 to 50 students via mobile crisis. Last year, we ended the year with 252. So because of our staffing didn't quite match the needs of our community, we were able to advocate for additional staff. So this year, we started the year off with capacity to bring on one more additional staff that has really helped us in meeting additional deliverables, along with serving the community, our young people in crisis, the families who are supporting a student in crisis. Initially, we didn't have case managers, but we learned that our crisis responders would not be able to truly provide brief case management in a predictable way while responding to crisis, because crisis is unpredictable. It could come anytime. Last year, it wasn't unusual for myself and the two responders to go on 2 crisis calls a day. So that let very little time for that aftercare, following up with the families, checking in, seeing how they're doing, seeing what next steps we can support them with within the perimeters of brief case management. So once again, the advocacy that our numbers showed and the story allowed us to bring on 2 case managers to support us with that aftercare, and also the psychoeducation that we do. Not only are we responding to youth in crisis, we're doing that preventative work. We're going into classrooms. We're talking about suicide prevention. We are hosting trainings, evidence-based trainings for school staff, community members, parents, so they know the signs. So we've really approached youth in crisis from a full perspective. All of our staff, all of our crisis responders, shall I say, are certified to do the involuntary hold. So that alleviates the need for police officers to be involved in most situations. Of course, we have access to police officers in case a family or a student is not in agreement with our decision to write an involuntary hold to keep them or others safe. We also may involve police officers if there's a need to do a warning to an identified victim, as it makes sense. All of our responders and our case managers are skilled in suicide prevention interventions, how to assess, identify concern, and what the next step should be. Our responders are trained in crisis intervention and de-escalation. So when we respond to a crisis call, our hope is that we can intervene and de-escalate that student. Usually it is effective, and we'll talk about our data, but it's essential that we know what words to use and what words not to use. Also, infusing in trauma-informed practices in our de-escalation, even how we position ourselves based on the information we know. And as information evolves, being aware of our body language and what nonverbals we're sending the student we're serving, how we're setting boundaries within that crisis assessment with school staff, and even the parents if a parent is agitated or just overwhelmed with emotion because they've just been informed that their young person is struggling with thoughts of suicidal or homicidal ideation. We have experience with the assessment, and we're continuing to learn from each other. We're continuing to attend different trainings and read books because we want to make sure that we are on top of the curve when it comes to being well-versed in how to not only do suicide, but homicide assessments. We offer safety planning. And when I say safety planning, the reality is whether we create a plan that young person transitions from the school site or home with their guardian, or we write in voluntary hold. Both of those intentions are to keep that young person safe. So when we say safety planning, it's broad and also includes that safety plan that young person can take home with their parent and implement the next day at school. We take a conscious step to be culturally aware. We understand that no one is an expert, but not only do we learn from our culturally diverse team, we look for experts in the community to learn from. And it's an ongoing part of our culture and something that we continue to look forward to evolving. We are even planning next year how we're going to be more culturally involved and having those hard conversations. And we're going to talk a little bit about how we establish a solid team, because doing this work, it's so essential that our team is solid. And of course, documentation. When dealing with this level of liability, documentation is essential. So we review documentation, feedbacks provided, and staff are trained after a crisis. Before you wrap up that day, even if your crisis extended after hours, you need to complete that note. So we have that protection that our documentation provides. We also have our key documents, so our informing materials, because this is a clinical service that we're providing. Our phone triage is the start of our crisis evaluation. That's when a school site staff calls our school-based mobile crisis hotline, and we ask questions to determine if this is a call that we're going to respond to, or if that young person needs can be better met somewhere else. I'm going to go in more detail about that a little bit later. We have a risk assessment tool that was developed in-house by our local Solano County Solano County Behavioral Health. We use the same tool. It's a questionnaire that we go to that really lays the foundation so we can decide what our next steps are going to be as far as how we're going to safety plan in collaboration with the school site and the guardian for that young person. We have the safety plan form that we fill out if a young person doesn't meet the criteria for involuntary hold, and that's done in collaboration with natural supports, guardian, and school site staff. We want to make sure we always have our involuntary hold form with us, because we don't know what we're going to be responding to just based on the phone triage. So we go in there, we enter the school site, not really knowing which way we're going to go. We keep an open mind, and we really allow the young person to dictate next steps. And of course, resources. We have resources readily available at time of crisis to provide the family. And then after the crisis, with that case management, we have the capacity to explore additional resources for linkage opportunities for that family. So protocol and workflow development. This, I have learned, is a evolving process. Each time you add a team member, the dynamics shift a little bit. Each time you add a position, the dynamics shift a little bit. So with our case managers, a new workflow had to be developed. And my initial workflow was adapted based on what I thought was going to happen and the real world experience of doing that. So that's not something that I do in isolation. I hold the responsibility of updating the workflow, but I'm checking in with the team. I'm checking in even with our secretary to figure out what is working for our secretary, what's working for our crisis responders, what insight do our case managers have. And not only do they speak to their own role, they speak to their observations of others. And we're brainstorming, how can we provide better services for the community, for the schools that we collaborate with. And of course, our workflow is visual. It's not just something that we say and verbalize. It's something tangible that people can go back and reflect on. I also use colors because for me, that helps, just separates who roles are which. We want to make it as accessible to our team as possible, so there's no question when they go out and serve the community. And it's also important that the responders know they are not working in isolation. Yes, our mobile crisis responders go out by themselves to the school site, but I'm available to consult as needed when they're having challenges around reaching guardian or parent, when they're not quite sure what the safety plan is going to look like. I'm a phone call away. And yes, there's times where I do respond to mobile crisis in the community, and then I lean on Camden, our director, or other clinical supervisors so they can provide that support. So it's so important to myself and even my team that we know when we go out, we're not in a position where if we're not sure, we have to make a decision by ourselves. We can process it and come up with a decision that has different perspectives. So when it comes to our partnering, how to make this new thing work, we have this visual right here. We support at this point 6 school districts and 1 city outside of the boundaries of our Solano Office of Education and County. So that's actually involves a partnership not only with another school district, but another Office of Education. And this is just a visual of what it looks like. On the right-hand side, you see in green, those are the majority of the phone calls we get when a young person is in someone's office and they're following, rules and they're being safe. And somehow it came to the staff's attention that they're at risk of killing themselves, seriously harming someone else, or the combination of, but they're compliant and they're safe. Sometimes it's because a student reached out saying, I have unsafe feelings. It could be because they looked at something online and it raised a red flag and administration or mental health staff brought them in. And a lot of times it's because maybe they said something to a young person, a peer, or they posted something and their peers are coming to us. We've even had peers' parents say, hey, I saw something that's alarming and I want to share this information with you. I have personally responded to a young person who their guardian was like, I don't know what to do, I need help. And so they brought the young person to the school, and the school reached out to us that morning of letting us know that this parent has concerns and this is why. In the middle, in the orange, those are situations where we may consider a co-response. This is when a young person is agitated, but they have a history of de-escalating, or a young person may be outside of the perimeters of the school, yet across the street, staff has eyes on them. They typically return back to school. We want to be mindful of our involvement with police and SRO because of the stigma that is sometimes there. Yet we also see that as a tool that if we partner with them, they can support us in keeping the young person safe with the understanding that we even clarify with the young person. Once you come back on site, we're going to take the lead. They're just here to make sure you're safe since you're outside of perimeter. So the partnerships are so important. And I'm so grateful for the few opportunities that we've been able to coordinate and collaborate with our SROs, because a lot of our SROs, they're a part of the communities that they serve. So they can even give us information or share concerns they have around their observations, decline in functioning of young people. And the left-hand side, the boxes are in red. These are the situations that we will not respond to if there has already been an active assault, a crime has obviously occurred, or the young person appears to have overdosed or is experiencing some physical, medical concern, or maybe the young person literally just needs medical attention first. I received a call from an elementary principal last year, and I'm walking her through the phone triage, and I don't know how it came up, but I believe it came up when I asked, has this young person digested anything that you're aware of? And the principal shared that the young person had a seaweed snack pack and ate the silicone packet. And I started asking, how is he looking? And the principal gave some details. And I let the principal know that we would not be able to respond because that's more appropriate for her to call 911. And I walk her through the process of what to say to highlight this young person had digested this with the intent to harm themselves, and they have already verbalized a desire to kill themselves. And so it's so important as a team. Not only are we supporting young people in crisis, but when school staff are working outside of their norm, working outside of what they expected the day to look like, it can send them in crisis. So in this space, we may think, oh, well, that was obvious. But once again, we're supporting not only students in crisis, but a system in crisis. So what does our daily operations look like? We have a school-based mobile crisis team and our hub, which is centrally located within our county. So we, in best weather, in the best traveling conditions, we can access every school we serve within 30 minutes. And we have the potential to serve over 95 schools. We're going to talk a little bit more about risk assessment, follow-up, and linkage. And most importantly, we're going to talk about the data, because the data tells the story. So on the left-hand side, you see the majority of our teammates. You see our case managers, our mobile crisis responders, and it's so important that we take opportunities to enjoy each other, celebrate each other, because this is hard work. So when we're not responding to crisis, team building, enjoying each other is so important because the work can be so stressful. Then on the right-hand side, this is our tracking board. On the top, it shows, we usually have staff's name, which staff are on duty. You'll even have the supervisor, because I sometimes respond to calls. We're tracking the calls, where the staff is, what time they left. Typically, our calls take approximately 90 minutes. So if a staff has been gone maybe 2.5 hours and we haven't heard anything, that's when we start reaching out to the school, making sure they are reaching out to our staff at the school, making sure they don't need any additional support. There are situations where things outside of the norm happen, and while they're supporting the family and the young person, I need to be doing some case management on the back and collaborating with our partners to make sure everyone is on the same or has the same idea of how we partner best with each other. This is an example of our phone triage. It's over the phone. Some of the questions we want to ask: is this homicidal, suicidal? Is the young person gravely disabled? Or is there another concern that you have? And then we just document that information. This is our risk assessment layout. So this is something that happens in person at the school. This is a way that we make sure that every student has access. Not only do we serve Medi-Cal, but we serve private insurance too. It's an interview. We use observation. We use if there's any documentation that supports whether we should do it in voluntary hold or not. We're even at times, especially with our younger students, our 6-year-olds or 7-year-olds or 8-year-olds, we're looking at recent art that they maybe submitted or drew at school. And we're also taking in, what is their guardian saying? What are their concerns about their young person? What is the guardian's interaction with their young person? That's all the things that we consider before we determine whether or not this is a safety plan or the involuntary hold. And if we do choose, if young person meets criteria for the voluntary hold, we are letting the school administration knows, because they need to know that medic is going to come to their school, and we need their support around figuring out how do we protect this young person's confidentiality in the midst of a crisis, but also transition them from the office within the school to outside of the school where medic is. Let's see, did I miss anything? And parents, guardians are aware of what our outcome is. We never do it without guardian involvement. Unless there's a rare situation where guardian's not responsive and we haven't been able to outreach to guardian using emergency contacts, which is rare. I believe it only happened once. And then after that, we're continuing to follow up with guardian, call them, utilize our partnership with the school to reach out to the guardian. So this data was submitted in February. So from August, the beginning of the school year, to about mid-February, we had served 133 students. Of those 133 students, 116 of them are unduplicated. So approximately, 17 students or 17 crisis response were students that we had responded to previously. And a success of that is oftentimes when we respond to a student, it paints the story of what that student needs are. And there are certain students that don't function at their best in mainstream schools. And so there was a young person, I believe we responded to them thus far 4 times this school district. And our last response, they had transitioned to a more contained learning environment, but it happened to be outside of the other school districts. So we were able to respond, share the safety plan that we created before, enhance it, and provide that to that student. And that student even disclosed in the midst of that call that they felt more supported because there was a familiar system in this new environment. And that environment, that new school system did not have to start from zero. We brought in elements that were working before, and we were able to rule out what hadn't worked and evolve it based on the resources that this other school system had in place. So even though we're serving young people maybe more than once, there's a benefit to that. And also with those students, we're advocating on the back end, what other resources, what other mental health resources are available. We're advocating for full service partnership mental health resources if they weren't already a part of that system. And as of February, when this date was compiled, 78.2% of the students we serve, the crisis responses are safety plan. And that means that they're transitioning home with guardian after our call. Those are students that aren't going to the emergency room or the CSU and just sitting and waiting to be evaluated. Those are students who we brought the mental health professionals to them at their school site and invited the parents and the school system in that conversation, because we truly believe when it comes to healing and thriving, that happens in the community. It doesn't happen in a psychiatric facility, in the emergency room, even though that does have a place when it comes to keeping that young person safe. The healing, the growth happens in the community. So when it comes to data, I typically look at data as it relates to everyone we serve, and that is looking at ethnicity, who we're serving by, gender identity. How many of our students are identifying as transgender or non-binary? We look at sexual orientation. What are the kids having? What type of risk? Is it homicide, suicide, or the combination of? The means? What is their plan to harm themselves? Do they even have a plan? Along with how many young people we write a safety plan for, and how many young people meet the criteria for involuntary hold. Yet when it comes to our partners, I'm able to isolate the data by district and share that with them. And that allows us to have a conversation, to ponder. So this is the county data and this is your data. Are you higher in any category related to the general county? And then we can start having conversations. How do we support certain populations? Are there resources that we need to explore bringing into our community? Are there resources in our community that maybe you're not utilizing, but your students could benefit from? And this is our data. This is an example of what we provide our community. You can see when we look at race and ethnicity, 31.6% of the students served identified as Caucasian or white, 29.1% identified as Hispanic/Latino. We have a tie for 13.7% that identified as African-American/Black or other. Others typically are biracial students who identify as being more than one race. And then 12% of the students served identified as Asian American, Pacific Islander. As it relates to gender identity, the majority of those served at 50% at this time was female, 37.3% identified as male, and 11.9% identified as transgender. When it comes to means, 40.2% did not have a plan, had not done any research, but had the desire to hurt themselves. And there's a smaller percentage of unrevealed because they just didn't disclose it. If they're not willing to disclose a plan, but they admit that they have done some research and there is a plan, we know it can't be disabled. And those are kids that more times than not, we write an involuntary hold for because they're not committing and participate in the safety plan.